Know if Jesse got last week's lecture or not. So let's put it this way, I did some real kind of soul searching, and Nana, you look, are you red in the face?
Oh my God, you got cheeses?
Yes, I have both.
Did you get sunburned today?
I did.
Wow.
Okay, now,
UV4.
Nana, not to put you on the spot, but could you come up here in front of everybody, please? This ties, this is
Well, it's
good.
not like we can tell if you're getting ready, don't worry.
So,
Some Cheez-Its while you're at it.
He wants
one of the things we're gonna talk about is anaphylaxis today. Severe allergic reactions. Come on up here in front of the camera so you can.
Oh, is because,
Yeah, so we'll talk about things like hives, urticaria, it's called. But see how her face is red? This is what typical anaphylaxis looks like. It looks like a body-wide sunburn. That's a lot of times how they'll present. Thank you.
You're welcome. Good
How
job.
can we tell the difference between allergic reaction and summer?
Yeah.
In summer, well, if you add in that color with dizziness, stomach cramping, throat swelling up,
Makes it, yeah.
yeah. There's, but it was just a good visual, thank you, Renee. But I've seen more of that, almost what appears to be a sunburn than hives, and I'm kind of jumping ahead. So, what I was saying is I did some thinking. First off, these PowerPoints, I can't stand them. They are, and I've said this 100 times, that they are really written for the EMT curriculum. So there are some additional requirements for EMT that aren't in the EMR. So, and I'll just say when you guys take part 2 to become EMTs, we go over everything we talked about, but we add kind of more into it. Spend a little bit more time on things like documentation, because we have to do patient reports and LDF rolling again?
No,
Well, they just got
a cat incident.
Oh, okay. But unfortunately, because we decided to use this book, and for good reason, it tends to throw a lot of stuff. And I know going through the PowerPoints, I reread the curriculum for EMR again today. And really what's required in the state curriculum for EMR, I've been going a little deeper than I should have. So it's okay to give you some good understanding, but it's kind of bogging down, and I feel like I'm throwing a lot of stuff at you guys. So I kind of want to regroup. We're going to go over we're going to finish up the medical emergencies, and we're going to touch on respiratory and cardiac that we already talked about. Okay? So first off, any questions on anything from last week for those that were here? Or Saturday, I know we had kind of a smaller group, but did Saturday go well? Okay. And beyond medical emergencies, there's really 2 kind of big sections that we got to cover, and that's going to be the trauma unit and then special operations. And special operations is a lot, and I got to add in childbirth too. We are going to learn how to catch babies.
Yay!
Yep.
Who catches it?
Which it's not in emergencies, because childbirth, for the most part, is not an emergency. But that's something Jesse's very much looking forward to going over. So, let's kind of recap medical emergencies. Now, one thing you hear me talk about a lot is supportive care. This is really, when we get into the treatment of the EMR, this is the bulk of what the EMR does. And that's supportive care. So what does supportive care mean? Supportive care is based upon good foundational patient assessment. So we're identifying life threats. Is their airway patent? Are they moving air and breathing? And do they have pulses? And again, if we find difficulty in any one of those big 3, we stop and we keep working on that, and we don't move on until we get it corrected. So if they don't have an airway, we we'll continuously work to open an airway until we get that done. And then when they have an airway, then we can focus on breathing, so on and so forth. So those three areas, airway, breathing, circulation, priorities. You know, then we can do kind of that rapid head to toe, and simultaneously while doing ABCs, we are looking for exsanguination or life-threatening hemorrhage and putting in procedures to stop that. Now, we're gonna get into the trauma unit as far as bleeding control, some general guidelines on splinting, wound care management, which we haven't got into yet, so we'll dive deeper into hemorrhage control later. So airway, breathing, circulation, rapid assessment. We're giving some interventions as we go, so if someone's, I'll just use respiratory, someone's struggling to breathe, you look at them, they're struggling to breathe, we might not have a pulse oximeter yet, we might not have gotten vital signs yet, it is appropriate to just get oxygen going on. We're still gonna continue the rest of our assessment, come back to that, now we may add things like a albuterol or nebulized therapy. Does that make sense? So initial treatments, and we're always coming back to revisit. But supportive care is basically doing whatever we have to do to maintain airway, breathing, circulation. So if blood pressure may seem to be low or they're dizzy, lightheaded, we lay them down, make them flat. If they're having trouble breathing, we give them oxygen or assist the breathing. Respiratory unit. With respiratory emergencies, I always kind of really look at, there's three different differentials that we should think of. Is it a restrictive problem? And so when I put COPDs on here, and COPDs are really that emphysema, asthma, even you can add pneumonia in there. All those restrictive COPDs, down the line, if we have the ability, those are the conditions we should be thinking albuterol is a potential treatment. Oxygen therapy and albuterol. Infectious processes, these are, pneumonia can be included in there, but that gets into like your epiglottitis and your croup. And we see more infectious respiratory issues with pediatric patients. Obstructions, can be physical obstructions, tongue obstructions, and that's more of an airway issue. So opening the airway, using airway adjuncts up to relieving obstruction. The one thing I didn't include in there, and you can write down, kind of ties in with cardiovascular, is pulmonary embolism. And pulmonary embolism, who can tell me what a PE is again? Blood clot, where is it located? In the lung. And Renee, I will say, your picture is on the other side here.
I was wondering.
That is,
I was wondering if that was the
does
same.
anyone have the same?
It's
I'm
upside down,
drawing.
upside down, but.
It is upright, I flip it.
I had no idea you were that artistic.
Didn't want to ruin that. But, yeah, so the pulmonary embolism, well, actually, we have it here. That's where a clot, anywhere between here and the pulmonary arteries, all the way down into the vasculature in the lung. So, unfortunately, with the blood clot, there's not much we can do. There's even not much ALS can do. They're able to move air in and out. It's just the blood can't get to that spot because of a big clot is there. PE is kind of unique, but I have seen an increased incidence in pulmonary embolisms over the last few years. I will say, COVID, I started to notice professionally an increase in pulmonary embolism. And there's a lot of theory out there. We do know that with viruses, any virus has the potential to essentially thicken blood. So it's just more prone to clots. But PE is kind of that oddball. My recommendation to any EMS provider, any acute onset of shortness of breath, and I'll even back up. Do we know what acute means? So when I say acute, rapid onset. So literally within minutes. So if I acutely develop abdominal pain, meaning Might be eating, watching TV, and all of a sudden, my stomach hurts. That's an acute onset. So an acute onset shortness of breath, especially without any underlying disease pathology. So things like asthma, COPD, you don't develop them, you don't just wake up with it. There's a gradual development of symptoms, enough to usually bring into your primary care provider, urgent care, where you get diagnosed with it. You don't just wake up with it. Infectious processes, there's usually they were sick and it just progressively hasn't gotten better. So it doesn't just happen immediately. At an acute onset shortness of breath, without any underlying disease, for me, it's assumed to be a pulmonary embolism until proven otherwise. And it's something we cannot rule out in the field. There's some things as a paramedic, we can maybe see some EKG tracings that are consistent with PE, but not 100% diagnostic. It needs lab and imaging work, and that can only be done in the hospital. And what do we do for PE? Oxygen and diesel, or gas. You put the ambulance in drive and get going to the hospital. So if ambulances pretty much always used to be diesels. So if you ever hear the term diesel bolus, it means get them going to the hospital.
Diesel therapy.
Because there's nothing else we can do. So that's what that means. Cardiovascular, acute coronary syndromes, remember that was a really broad generic umbrella term. What we commonly think of as heart attacks or angina. Any chest pain, we can assume to be acute coronary syndrome, even at the EMR level. It's supportive care. It's being with them, calming them down, up to include aspirin administration. So I'll ask this, when do we not give aspirin? There's really two primaries. If they're allergic
Internal bleeding.
and suspected bleeding. So that can be GI bleeding or obviously we wouldn't give them a trauma, but really the only time we're giving aspirin to a patient is if they're having chest pain. Now, not all chest pains are heart attacks. In fact, I would say the vast majority of people who complain of chest pain aren't having a heart attack. But they still need to be evaluated, and EKG is a good test, but there is also additional testing at the hospital that needs to be done. We talked about rhythm disturbances, and this is where heart rates can get really slow or really fast. Again, not much we can do at the EMR level other than supportive care, comfort until ambulance arrives. Heart failure. Heart failure is just inability of the heart to pump, and what can happen in heart failure is blood gets backed up, and it can back up in the body, or it can back up in the lungs. Naya, could you shut that door?
Yeah.
Thank you. So a heart failure patient that goes into what we call pulmonary edema, or where fluid builds up in the lungs, their initial complaint is going to be extreme shortness of breath. So sometimes that cardiovascular patient can be assumed to be a respiratory patient as well. And our therapy for that is essentially just high flow oxygen. That they will look oxygen starved, their oxygen saturations will be very low. Aspirin in a heart failure patient, not really indicated. I mean, honestly, at the end of the day, is it going to hurt them? No, as long as they're not, we don't suspect active bleeding or they're not allergic to it. It won't hurt, but it's really not going to help much. Heart failure isn't a blood flow problem, it's a pump problem. Albuterol in heart failure, so, hey, I'm the EMR, ambulance is 15 minutes out because we're waiting for the ambulance to come from the other side of the district. What if I give a heart failure patient albuterol? Not with the dose at the EMR level. So albuterol probably isn't going to help much because with heart failure, it's fluid in those air sacs, the alveoli, or around the alveoli in the interstitial space. Albuterol is going to dilate the bronchial, the terminal bronchioles that are going into those air sacs. As we go trachea, bronchi, bronchioles, then the air sac. So it'll dilate them, it may allow some movement of air, but again, with heart failure, it's not so much a volume of air problem, the oxygen and carbon dioxide can't switch places through a bunch of fluid. It's much more hard for those gases to achieve. So you may give them albuterol, their heart rate will go up a little bit more, they might get a little bit more anxious, but it's not going to, in the picture of things, overall deteriorate. Just, you know, the ambulance might show up, a paramedic might take 3-4 minutes and say, stop the albuterol. Okay, and that's okay. If you initiated it and we stop it, it's because we have on the ambulance a little bit more diagnostics to kind of drive that down. So, but when in doubt, it would be appropriate, but usually those patients, you're gonna want just high flow oxygen. If I can give you some of my past experience, so your COPDs, your pneumonias, when I find them with their oxygen saturations are typically mid-80s to low 90s, whereas heart failure patients will be, if they're in true pulmonary edema, we'll see oxygen saturations that'll even say unable to read, that it's below 60. So the heart failures are extremely low oxygen. And then kind of the last one, I throw this in with cardiovascular as well as that suspected stroke. So Katie kind of went over what's called the DFAST. There's a bunch of different stroke scales. For years, we have the one stroke scale that I've always used is called the Cincinnati Pre-Hospital Stroke Scale. And 3 things that we check for. We check for arm strength or arm drift. And that's where I may say, Nate, I'm just gonna come up by you again. If I'm gonna do a stroke scale, Nate, I want you to close your eyes. I'm gonna pick your arms up and I want you to hold them there when I let go, okay? Okay, that's good, you can put them down. So if he holds them both up and doesn't move them, that's negative for a stroke. If I pick them up and one obviously drops right away, showing complete paralysis on one side of the body, that's a positive indicator for a stroke. If the arm begins to drift off or one arm is weaker than the other, that's also a positive indication for a stroke. So basically, arms stay equal, able to hold them still, that they pass that portion of the check test. So then we go into the second one, and that's facial symmetry. So I'll say, Nate, give me a big smile. Give a big smile. Good, thank you. So I'm looking to make sure his corners of his mouth both come up equally. Maybe he can squint equally when he smiles. Facial symmetry looks good. And then the last thing they'll do is speech. Nate, repeat after me. All dogs go to heaven.
All dogs go into heaven.
Okay. So words made sense. He repeated my words, and he didn't sound like he was slurred or intoxicated. That's my stroke scale. So again, I'll show you kind of real time. Nate, I want you to hold your arms out. I'm gonna hold them. I'm gonna let go. Keep them right there, okay? Good, thank you. Give me a big smile. Okay, good. Repeat after me. All dogs go to heaven.
All dogs go to heaven.
There, that's my stroke scale. Takes that long. So I'll do those quick rapid things. Now, if I'm concerned for stroke, I'm gonna dig in and ask some other questions. What Katie added in, the balance, you remember that, DFAST? So balance, obviously I'm not gonna, Nate, I want you to get up and walk around because you called the ambulance, right? I don't want you around moving, but when you were walking, how was your balance? I just asked. Or are you seeing does the room look different to you than it should? Do I look like I'm standing on a wall? And just ask them what they tell you. So the first part of that stroke scale, when we're checking arm strength, facial symmetry, and speech, we're checking the cerebrum of the brain. That main part. When you think of the brain, the main part. The cerebellum, that's that little kind of, I guess, looks like you got your main brain and then there's a little ball on the back side of it. That cerebellum is what is responsible for your spatial orientation. You tell us when you're upright. If I close my eyes, I know if I'm standing up. I know if I'm laying down on my back. When you have a stroke to that portion of the brain, that stops working. So they may not only have vision where it looks like the room is upside down or sideways, but they just completely lose their balance, almost, has anyone ever heard of vertigo?
Yeah.
Yes.
Extreme dizziness, right? So, any vertigo-like symptoms, for me, as a pre-hospital provider, is a stroke till proven otherwise. You know, can people have primary vertigo? Absolutely. But if you've got an acute onset, rapid onset of dizziness, unsteady gait, loss of balance control, you're a cerebellar stroke until proven otherwise. And you have to get some imaging for that in the hospital, yes.
You know, another thing you can look for, especially with someone who has vertigo, my mom has really bad vertigo, and I took her to the hospital not too long ago, and when I got to my house, both of her eyes had nystagmus.
Nystagmus?
Both of them.
You know, nystagmus is kind of one of those, and I'll say for those, if you've never heard of nystagmus, like if I have you follow my finger, and I move your eyes have you look right or left. And if I follow finger to the right, I'll stop. Now what I'm looking for is your eyes to follow and then do this little bounce. That's a nystagmus. And law enforcement does it a lot. You know, it's kind of, if you give me 3 Manhattans and do it, I'll have nystagmus. Okay, it's an indication of central nervous system impairment. It can be from a lot of things. So nystagmus is, and some people just have nystagmus all the time. So I'm sure you've all met someone when you're talking to them and their eyes are kind of constantly bouncing. Doesn't mean they're having a stroke, doesn't mean they're intoxicated. They just have nystagmus from whatever. They don't even know they have it. Their vision is interrupted, right? So it's kind of one of those tests that I don't really test for very much. Even rapid onset vertigo, probably one of the more common conditions that I've seen is something called labyrinthitis. Has anyone ever heard of that?
Say it again.
Labyrinthitis. So you're inside your ear, you got 3
Yeah.
little bones, right? And you get inflammation in those ear bones. Those ear bones work with your cerebellum to help you understand what's up, what's down. In fact, a lot of times pilots at night or divers, that whole equilibrium can get thrown off, where like divers might think they're swimming to the surface and they're actually swimming deeper because you lose that orientation, right? So labyrinthitis gets inflamed, infectious process, something happens. And boom, all of a sudden they're dizzy, they're throwing up, they can't open their eyes, they're pretty much laying flat. And I don't expect you guys to look at a patient and go, labyrinthitis, right? Acute onset of dizziness, vertigo, it's a possible stroke to prove. One other thing we do is we can look for, the name will come to me in a second, but I'm gonna come behind you, Nate. What I'm gonna do is I'm gonna put my hands on each shoulder. I'm just gonna say, I'm gonna tap a shoulder, let me know if it's right or left. So he's able to tell what shoulder I'm tapping, what shoulder I'm touching, where it might be opposite, but when he's having that sensation difference, you know, could indicate some type of a large vessel occlusion, right? So with stroke, there's not much, again, pre-hospital we can do. So we're not giving any medicine. You know, we don't want to give them aspirin. We do our stroke scale. Any positive findings, we want to let EMS know right away. We're going to try to move fast. That stroke is more of we really try to keep scene times to a minimum. So the ambulance crew may come in and without doing blood pressure or anything, throw them in a cot, say we're doing everything to the hospital. There's a time limit. That if it's a clot-related stroke, there's medicine that they can give to break up the clot, but we have a very, very small window. So one of the best questions, or probably the most important question the EMR can get from a potential stroke patient is, when was the last known well time? So anyone who's with them, or you know, stroke, the patient is actually a pretty poor historian when it comes to that, but whoever called 911, who's ever in the room, when was the last time you've seen them acting normally? And we really want to try to drive down that number. Okay. So, you know, the we were just talking and all of a sudden they stopped talking to me and kind of slumped over in their chair. I know then, okay, we're within 15 minutes of the onset. What's unfortunate is when we go to a house and it's, couple wake up, get ready. Husband gets up, goes out, starts making coffee, goes in to check on his wife, and she's not getting up. She's awake, she's not talking. Her last known well time was at 10 o'clock the night before. So the stroke could have been 5 minutes ago, it could also have been 10 hours ago. We don't know, but we really want to know that last known well time. For us in EMS, we're going to activate a stroke alert to the hospital, and we're going to do that within 24 hours of last known well time. They're still going to do some imaging, but it's very time sensitive, and that the medicine we give is, there's a lot of risks, complications with giving. Now, the hemorrhagic strokes that occur from a brain aneurysm or a burst blood vessel, those typically present much differently. So those types of patients will initially activate 911 for a headache. And I always, red flags go up when 911's coming in for someone with a headache. Most people don't call an ambulance when they have a headache. So when it's that bad that they're calling 911, to me that's a red flag. And usually all of the different types of hemorrhagic strokes are preceded by the worst headache they've had in their life. Now these patients will generally present with rapid deterioration in their mental status, which means they can still be talking when you get there, and before we leave in the ambulance, they're completely unresponsive, that they will deteriorate very, very quickly. And that's what, unfortunately, there's not much we can do for those types of strokes other than, again, supportive care, support their airways, support their breathing. We gotta get them to a hospital double quick. I guess the other thing I forgot to throw in that cardiovascular was aneurysm. So that can be pain anywhere between the neck and the gut, and it's usually a severe ripping, tearing type sensation, and they'll look shocky, pale, sweaty, and those patients we just gotta move.
That's all their only symptoms?
What's it?
That's the only symptoms? Is that their only symptoms?
No, I mean, there can be, there's a lot of varying degrees, but depending on where that aneurysm is. So somewhere in the aorta, coming up off the heart, down through their chest cavity, through their abdominal cavity, down into their groin. Depending on where it's dissecting, where blood flow may be getting limited, you may see if it's up in the chest, you may have unequal blood pressures in right versus left arm. So, like I've got, coming off that aorta, I've got an artery that goes to my brachial arteries on my arms. If blood supply is disrupted to the vessel going to my right, blood pressure will be different on the left than on the right. I've also had aneurysms, abdominal aneurysms, where they're complaining of they feel like they have to defecate, but they can't. So they've been on the toilet for like an hour, and they feel the need, they gotta go, but nothing's coming out. And that's because that aneurysm is pushing on the same part of your gut that tells you you need to go to that. So it's not stool that's gotta come out, it's you got this big blood vessel that's already burst. I've had one or a couple that I've seen, they've completely lost use of their legs, just like that they're literally, all of a sudden, the legs just quit working immediately. And it's just because blood supply got disrupted to those legs. So every aneurysm I've seen, they've been pale, diaphoretic, looking like they're in shock of some type. So heart rate's going up, blood pressure's starting to go down. And again, pretty much supportive care. There's not much else that we do even at the paramedic level other than get them to the hospital. Anywhere you have a blood vessel, you can have an aneurysm or a rupture. Altered mental status. Altered mental status, we can go really, really deep in the weeds. Now, we've got a lot of I shouldn't say it. We don't have a lot of diagnostics even at the paramedic level. We're going to kind of check on the same things with any altered mental status. So altered mental status can be where they're just not making sense, or like I had talked, where they may know their name, the year, confused maybe on the day, but it's still altered. And we're trying to see, are they alert to person, place, and time, right? But there may be other components of that just aren't making sense. So they're altered. To the point of altered mental status may be as severe as they're just unresponsive. Breathing, got a pulse, got a good blood pressure, they're just unresponsive. So there's all different degrees, all different things cause it. Don't ever assume. Altered mental status tends to take providers down assumptions pretty quick, and I'll give you an example. 2:30 in the morning, you're dispatched to the parking lot of the Drop Shot in Prescott for a man in his car unresponsive. It's 2:30 Saturday morning.
He is
What
passed
thoughts
out.
are you hammered, right? Well, no one's there to tell you, although the bartender, had she been there, might have said, he comes here every Friday night for Fish Fry, and he sits down, visits, and drinks Pepsi all night. We don't know, and so never assume that someone, they're just drunk. Okay, never assume that. But there's some things we're gonna check, airway, breathing, circulation. We'll do a head-to-toe assessment. Do we see a bullet hole in them somewhere, right? There's a test, and we'll probably quick show you guys tonight, blood sugar. So if you have the ability to carry a glucometer, that's probably the most common thing that we can check as EMS providers, to include EMR, to determine, to rule that in or rule that out. I'm gonna talk about diabetes tonight too, just pretty quick. But check their blood sugar, otherwise it support their airway, breathing, circulation until we get there. But there's a lot of things that cause altered mental status. Might it be acute alcohol intoxication? Sure.
Could be.
But can drunk people have aneurysms?
Sure can.
Yeah, absolutely. So we may smell alcohol, just doesn't mean it's just alcohol. That's those non-life-threatening things, we come to that after we rule everything else out.
So say that he was in his car, and so in a situation like that, would you say you were the EMR responding to it, are you gonna pull him out and just lay him on the ground? Or what would you do in that situation?
That's a really good question. So, the brain always wants to go to these, what if it's one of these people that are committing suicide in the car? Put some chemicals in their car. Can I talk about this? There was a couple of years ago that it was, and I've never seen it in my career, but you can mix chemicals in a car, shut your car doors, and then it's an enclosed space, so whatever fumes that chemicals, you die from it. It'd be, as simple as taking a gallon of bleach and a gallon of ammonia, and dumping them together and just rolling up the windows. That gas is going to kill them. Usually those that they got a sign on their door, do not open windows, because they don't want any, they just want to kill themselves, right? This is what I've read from literature. I've never seen that case. Usually on that type of case, especially for the EMR, my recommendation would be your comfort level. I know that's probably not the best thing to say, but I can almost guarantee you law enforcement is going to be going on that call. So I would let law enforcement get them out of the car, or make the scene safe, even the car safe. Let law enforcement do that. If the car was running, I'm gonna try to open the door and quickly shut the car off. That's me. Shut the car off, put the keys in my pocket, because I don't wanna rap on the door, have someone wake up, put it in reverse, and now we've got a problem.
Right.
Because we've got someone driving who's altered, and now we're putting, all the other vehicles on the road are at risk. But I'd say if you pull up and law enforcement are here, you just back off, you get on the radio, say, how far out is law enforcement? Let them do it. That'd probably be the safest. That'd be my recommendation as an instructor. Just don't put yourself in a bad spot. And if they do put the car in reverse, take off, just make notification, hey, they took off, they headed that way. I'm gonna wait till they crash or you find them and then come check them out then, right? We're not gonna chase them.
Right.
That's not our job. Like I've had opiate overdoses that we Narcan, and they wake up, rip out the IV and they take off running. Bye. I'm not chasing them. Just let them go. That's now becomes a law enforcement problem. That answer the question? But yeah, altered mental status, the big thing there is check the blood sugar. You know, do they feel warm to the touch, cold to the touch? You know, they can start taking us down different roads, but it's mostly supportive care. Seizures, we'll kind of tie into seizures. I'm gonna watch this, so. Let's talk about seizures and I'll give you a kind of a quick break and then we'll jump into diabetes. So, there's really all different kinds of seizures. The seizures where EMS gets called are going to be classified as kind of generalized seizures. Now, I can't remember how they differentiate. There used to be simple seizures, generalized seizures, and I apologize for not being all up on the terms. But a generalized seizure, the generalized tonic-clonic, these are when I say the word seizure, this is what you're probably picturing in your brain. This is where there's a loss of consciousness, twitching, convulsing, right? So with seizures, people who have, especially a seizure history, is usually preceded by what's called an aura. So if you know anyone who has epilepsy or seizure disorder, for the most part, they can tell you that they have some brief moment in time, sometimes a couple seconds, sometimes a couple minutes, sometimes an hour, that they know a seizure is coming on. And the aura can be a lot of different things depending on the person. It can be they get a taste in their mouth, they get all of a sudden they'll get this strong metallic taste and they know I'm going to be having a seizure here soon, or a certain smell, but something happens preceding it, and then they go into their seizure. So the tonic-clonic, which is the one we're thinking of, it's a tonic phase followed by a clonic phase followed by what's called a postictal phase. So tonic means stiffening of muscles, that they'll just stiffen up, and then they'll go into the clonic where they start the kind of convulsings. Now during these seizures, they're not breathing. So they'll get really purple, really red, and really blue, and then the seizure will terminate. After they've kind of gone, it's like if you hold your breath, what's going to happen? You will pass out because your brain doesn't get enough oxygen. So your brain shuts off, puts you on the ground so that you will then just start breathing again. So the generalized seizure then goes into what we call this postictal phase, and that can last anywhere from minutes to, I think the longest I've seen is close to an hour. Really groggy, they're not talking, it takes them a long time to come out of it, if you will. So during the actual seizure, what do we do as EMR? Nothing. We do absolutely nothing. We let them have their seizure, we get things cleared out away from them, so, you know, and it's not like they're, you know, jumping all over the floor, but if there's a table close by, that the big risk with the seizure is, did they hit something on their way down? If they start to vomit during the seizure, we can do our best to maybe get them on their side, you know, but immediately after the seizure, when the seizure stops, that's where we need to assess them. Get them in the recovery position. You may need to support airway, do a head tilt chin lift, and immediately after, they will be unconscious. And then they'll just kind of slowly start waking up. So mostly supportive care, keeping the airway open, be ready for them to vomit. I will tell you, in my experience with seizures, very seldom do I see them vomit. The seizure isn't as concerning as what might be causing the seizure. So a lot of things can cause seizures. I'll even, on the worst case, cardiac arrest. So prior to when someone's heart stops beating, it's an immediate loss of blood flow to the brain. And whenever you lose blood flow to your brain, it's very common to have a seizure. So someone will have their seizure, and as soon as they stop, we need to assess them. Do they got a pulse? Are they breathing? And if not, we do what we got to do to support that. Okay. Epilepsy is probably the most common cause of seizure. It's a diagnosed condition. And when they wake up, they're gonna tell you all about it. They're gonna know more about their epilepsy than you ever will. So those are about the only times we don't transport after a seizure. For known epileptics, they wake up, someone's generally with them, we check them out, make sure their blood sugar's good. Low blood sugar can cause seizures, strokes can cause seizures, infections can cause seizures. Has anyone ever heard of a febrile seizure?
Yes, I can tell you
Fever,
what it is.
or fever.
Yep. So febrile seizures are pretty common, especially under the age of 3. You can see them, I guess, in all pediatrics, but it's generally 3 and under is the most common, down to infants. And it's not so much what their fever is, it's how fast they got there. So, let's just say 6-month-old gets some infection. And over the course of a day, they go from normal body temp to 102, right? Probably not gonna cause a febrile seizure. But if that happens within 30 minutes, there's a potential. Now, febrile seizures are relatively common. It's the most common, and again, I'm just speaking off my experience, but it's the most common cause of when we get the call for the baby not breathing. So you get a call, infant, P&B, cardiac arrest. We get there, baby's crying, screaming, warm to the touch, red, and that's generally what happens. While feeding, had a seizure, went postictal. Rightfully so, parents were scared, pardon my language, but shitless. Activated 911, we get there. That's what I pray for, is that anytime we get called for a baby not breathing, I'm like, please be a febrile seizure. So febrile seizures in infants are what generally, for the most part, uneventful transports. Means they have their seizures, by the time we get there, they're coming out of it. We work on some passive cooling to cool their body temp down. We may start some IV Tylenol on them to help bring their fever down, but it's supportive care. It's oxygen if they need it, check their blood sugar, rule out some things, and just take them to the hospital. They'll check them out and discharge them, right? But we also don't know, does this baby have a brain tumor that nobody knows about that may have caused a seizure? So that every seizure, for the most part, should be evaluated, especially if it's a first-time seizure. The other types of seizures, the more partial ones, can be characterized by, they may just kind of, if you will, space out for 30 seconds to a minute. You may be talking to someone and all of a sudden they just stop responding to you, and they maybe flutter their eyes, or they'll do some twitching or some type of clonic motion, just. And then they come out. Now, those types of seizures, they generally don't have a postictal phase after it, and it's very easy to not even realize they were having a seizure. So for those patients that have some kind of tic temporarily and then it goes away, I'm concerned of a potential stroke, and that's just what we're gonna work for and get to the hospital. Have scan and rule it out. Seizures, and it's also common to see them bleeding from the mouth because they bite their tongue during the seizure. It's really nothing that requires our intervention. It's no different than any of you. Has anyone ever bit their tongue before? Not fun. Did you die from it? Well, obviously not if you're here. But you'll see they'll have some blood coming out of their mouth, and we're not talking copious amounts, but a little bit of blood. And then hey, when they wake up, stick your tongue out for me if you see a laceration on their tongue. They probably bit their tongue during the seizure. So, but otherwise, seizures are mostly supportive. The best thing we can do is just clear everything away from them. Try to get people who don't need to be there out of there, and retain their privacy. So it's also pretty common during a seizure that they'll probably become incontinent to urine. So incontinent just means they urinate themselves. Maybe potentially defecate themselves too. So imagine you're at the grocery store trying to decide if you want Lucky Charms or Cookie Crisp, and all of a sudden you wake up and you shit and pissed your pants. Kind of embarrassing, right? So try to get everyone out of there that doesn't need to be there, maintain patient privacy. you know, that kind of, I guess, embarrassment, if you will, could trigger another seizure. So we just try to keep everything as calm as we can, keep, you know, if ambulance is outside, they're flashing lights, we shut the lights off, we try to keep it as calm environment as possible. Now, the true kind of life-threatening condition is what we call status epilepticus. Status epilepticus is repeating seizures without an intervening level of consciousness. So they have a seizure, they go postictal, they have a seizure, they go postictal, and this cycle just continues. So that's status epilepticus, and that's where usually ALS, we have to give them medicine to terminate that seizure. Benzodiazepine, like a Valium, if you will. Sometimes kids will have, especially special needs, are more prone to seizures. The parents are very well versed on medication administration, so it would be very reasonable for us to get dispatched to a house for a kid who's been having seizures for 30, 45 minutes. And if you ever get paged and you're thinking, why didn't you call us right away? Because the parents are doing what they've been instructed to do by their provider. So the doctor will tell them, hey, if your kid has a seizure, first one, just watch it. And if they have another one, then you do, and then they'll typically give like rectal Valium, a syringe, they squirt the medicine up the butt, and hopefully that terminates the seizure. Sometimes give another dose, and then if they're still seizing, then call 911. So there may be times that if you get called for people who've been having seizures going on for 30, 45 minutes, and this can even be, you know, not only kids, but you can see it elderly too. Like, I don't know if Lac Flambeau, you guys have a assisted living or nursing home?
Yeah.
Okay, it can be very common there where the nurse may say, it's been seizing for 30 minutes, and we've done this, this, and this, and now we've hit the trigger to call 911. So it's not because they're doing poor care, they're following, you know, the order. It's just like heart patients, the doctor may tell them, hey, you get chest pain, take up to 3 nitros, 5 minutes apart, you know, don't take all 3 at once. Take a nitro, wait 5 minutes, take a nitro, wait 5 minutes, take a nitro, wait 5 minutes. So if you did 3 nitros over 15 minutes and you're still having chest pain, then call 911.
So if they're on the ground having a seizure, and they're banging their head against the ground, you're saying you're not gonna...
I mean, it would be reasonable, you know, you can put your hand under your head. I think the big thing is you especially don't want to be, like, get your hands anywhere near their mouth. They could bite very hard, so you don't want to get bit. So don't, you know, we used to carry bite blocks in the ambulance. It was like a plastic screw. Drew in so they didn't bite, but we don't do that anymore. You know, if someone's head is banging on the floor, and I usually, when I see the convulsions, it's usually arms and legs, or it's you know, they're on the ground kind of doing that. Very seldom do we still see the seizures when we get there. It's usually one seizure, it's done by the time we get there. You know, they might be kind of out of it, especially kids. That's when we quick do all their stuff, do the IV stuff, blood sugar, we do all the meal stuff quick while they're kind of out. You know, I don't want to wait till they wake up. And then most times it's just an uneventful ride to the hospital, and their level of responsiveness just gets better, it gets better, it gets better. The only times I will immediately terminate a seizure is if I'm suspecting a stroke, or they've got really high blood pressure, or a suspected brain injury. Those are things where we don't want them. So as soon as I see them start to seize, they're getting some type of medicine to suppress that. But there's nothing really at the EMR level. There's no medication. There's nothing we can do to stop seizures, but we can prevent additional seizures by just keeping the environment calm.
The grand mal seizures fall under the tonic-clonic.
Yep, that's a tonic clonic. Grand mal, same thing. And I'd say those are the most common when we're activated for a seizure. That's the type of seizure it's going to be. But you don't talk, you know, as they're coming out of it, witnesses, you know, do you remember if they, you know, were they using both arms? Was it just one arm? You know, things like that. Try to narrow down and get a picture of what it is. Most people aren't paying attention enough. And in an emergency, they lose track of time. So, I mean, you can ask, how long were they seizing? I always get a kick out, well, they were seizing like that for 5 minutes. No, they weren't. You can't hold your breath for 5 minutes. Has anyone ever heard of a pseudo seizure?
What?
Pseudo seizure. So pseudo seizures are a legitimate medical condition, and they will look like they're having a seizure, except it's kind of ongoing, but kind of the big difference is the breathing. And it's not important for you guys to differentiate, but like if Nate's sitting there just twitching and he's not responding,
Jesus.
you yell a name like that, but if they're having a pseudo seizure, that's usually enough to kind of snap them out. So everyone okay? So, if you hear us yell at a patient sometime on the ambulance, that's kind of what we're doing, is trying to, are they having a pseudo seizure or not? But don't take the name pseudo, meaning false, as they're faking it.
It's just not as
In
necessarily as.
fact, I'm just gonna put that umbrella out now. In EMS, we never assume anybody's faking it. That, has anyone ever heard of a drug seeker?
Yeah.
So healthcare, we run into drug seekers, where people will call an ambulance because they want pain medicine. They will fake an injury to include, a patient on my previous department would actually dislocate his shoulder. Now, he could pop it out, pop it in, and he had that ability. But it took close to 6 months of us picking him up like every other week, giving him fentanyl or pain medicine, before the hospital called us and said, hey, so this guy, he is dislocating his own shoulder. So when we pick him up, medical control tells us he gets an ice pack, and you can bring him up, we can't deny transport, but we give him an ice pack. So we'd start doing that, saying, hey, we're just gonna give you an ice pack and see how that does. And he would get mad until at what point, once he realized we weren't gonna give him fentanyl, he got up and just walked out of the ambulance. Actually popped his shoulder back in while he was walking out of the ambulance, went back in his house and shut the door, so. Okay, but we're not going to, it takes a long time before we get to that trigger point of, all right, they're probably abusing, looking for drugs. But we never assume it's a drug seeker. We never assume they're faking it. We never assume they're drunk. We still do our assessment and go through all that stuff. Now, if they are faking it, when we get them in the ambulance and start doing pointy, sharp things on them, they tend to start coming around pretty quickly, especially if you ever mention the word Foley catheter. That wakes a lot of people up pretty quickly. Which, we mention it because we'll probably need to put a Foley. I'm not trying to be mean or, by me saying, if you don't wake up, I'll put a Foley catheter in you, that's assault. So they could press charges against me for assault. So never assume. Has anyone ever taught during patient assessment, and you don't have to say it, but did anyone ever say if someone's unconscious, hold their hand over their face?
It stays.
Okay, so don't do that. If you can imagine, I'm laying flat on my back and I'm unconscious, right? I'm not responding, I'm not talking to you, I'm just, but I'm breathing, I got a pulse. I can't fake that. That if you take their hand and hold over their face, if they're not faking and you let go, they'll hit their face. But if they're faking, they'll, just kind of lightly. Well, I used to do that. I was taught that. And we had a case, and in fact, I'll kind of tie this in and then we're going to give you guys a break. Dispatched to a bowling alley. It's 11:30 at night. The bowling alley has a bar in it. Usually pretty packed. So we've got a female patron that's in the bathroom, and she's just not responding. So we go in there, and she's sitting on the toilet, clothes on, not like just sitting on the toilet, and she's got her eyes clenched shut, and we'll say her name was Barb. Barb, what's going on? What's wrong? And she wouldn't, other than wouldn't respond to us at all. So we put her in a cot. She's got a blood pressure, pulse. Everything seems okay, and lay her back, and you think, well, she was at the bar. She's probably hammered. Well, the bartender comes in and says she has not had a drop of alcohol since she's been in here. She's been here went to the bathroom, she's been in there for like 30 minutes, that's when we went in to check. So we did the old, put the hand above her head, let go, and she just, brush. She's faking. We're 5 minutes from the hospital, so we're on scene 10 minutes. Get her in the ambulance. We didn't even put an IV in her, just assume she's faking it. And the story was her and her husband had gotten into kind of an argument right before, so she's faking it, right? Well, before we got to the hospital, she was irregular respiration, she had a blown pupil, she had a massive brain bleed. Now, we didn't do anything to make it worse. We were short time on scene, we're going to the hospital. There's nothing we could have done to have changed that. But I had that brief assumption that she was faking. She wasn't, and she died within 20 minutes of arrival at the hospital. Massive subarachnoid bleed. This call was 20 years ago. I remember like it was yesterday. So, never assume. Never assume. We're still going to do our assessment. We in the ambulance, we can check a little bit more, but we're never going to assume. We'll take them to the hospital and let them figure it out from there. Any questions on that stuff? Yeah.
So I do see like cops will use like a salt stick sometimes in those kind of situations.
I'm sorry. What's that?
A salt stick? You ever seen like cops using salt sticks? Some people are faking.
Ammonia salts?
Is that what
Smelling
those
salts?
are?
Yeah,
The smelling salt things?
Oh,
where
yeah.
yeah.
We don't, they're within scope, meaning scope of practice, you can do them. I don't wanna give, has anyone ever used a smelling salt?
No, but I have questions, like what does it smell like?
It is the most potent.
I'll bring one in.
Nasal. You will ever have in your life. Like weightlifters do it to like get their PR because there's a ton of blood flow to your head and just. Oh yeah.
It's like a legalized, probably like a legalized blast of cocaine or something.
Kind of.
I think if you're feeling like you're gonna fall asleep,
Actually.
you take one whiff and boom, you're.
Nice.
If you're unresponsive or somewhat faking it, it's a strong, like ammonia smell. Yeah. Burns. Yeah, it's good, but no, we don't, I don't need people like snapping out of it. No, I don't use them. I see where maybe some law enforcement would use them. Honestly, law enforcement, probably the first thing they're gonna do if something's altered is they would not be. Which, we'll talk about that, that'll be coming up under toxicology. Okay, let's take a quick break. Okay, well, let's continue. So let's dive into diabetes. Would you be so kind to grab a glucometer?
Yeah, we don't have a spare one, do we?
Hmm?
In case they get a call, should I get like?
If they get a call, we'll just run it out. I mean, we're just gonna do a kind of a demonstration and then one of these Saturdays. I won't make you guys pull fingers, but
Dang it.
You poke my finger.
we can check blood sugars. Huh?
I said, you poke my finger.
Okay. We'll do a blood sugar
I
check.
volunteers to.
Deal.
I'm volunteering my
All five.
finger.
Hmm?
10 fingers.
Volunteers to.
I think that's fine.
I volunteer my finger.
Taking my sugars.
So, diabetes. Basically, three types of diabetes. I'm gonna just, the one that you'll probably never hear about is called diabetes insipidus. So, when people say I'm a diabetic, they generally mean it's an insulin sugar issue. Diabetes insipidus is actually it's a different hormone issue, specifically a hormone called vasopressin or antidiuretic hormone. The problem with diabetes insipidus is they think they're always thirsty, so they can just consume too much water. That it's more of a water issue than it is a blood sugar issue. I can tell you in my entire career, I've never ever had an ambulance call for somebody in diabetes insipidus or an emergency because of. Okay, so I just throw that out there. So that's kind of one diabetes that has nothing to really do with blood sugar in. So here's kind of the down and dirty of diabetes. Diabetics generally have problems has something to do with how their body is responding to insulin. So insulin is created in the pancreas, and insulin is the chemical that allows sugar to get into the cell. So if you don't have insulin, sugar just stays in the blood. It can't get into the cell to be converted to energy. So you have to have insulin as essentially that key that unlocks the door to allow sugar to get in. So one of two problems happen. Number one, you just don't make enough insulin. Or you don't make any insulin. Now, we typically call that type of diabetes insulin-dependent diabetes, meaning they have to take supplemental insulin injections or some insulin derivative. Type or what we used to call type 1 diabetics. So type 1, insulin dependent, and I'm not so much concerned when I'm asking, are you type 1 or type 2? I just, when people say they're a diabetic, I say, do you take insulin injections for it? So those diabetics are more concerning. We see more emergencies with insulin-dependent diabetics. Now, there's a lot of insulin-dependent diabetics, and just because they're an insulin-dependent diabetic, if they, they take care of themselves, they eat right, they take their insulin as supposed to, that they may never have an issue. So it doesn't mean every diabetic who takes insulin is going to be needing a ambulance. It's just not the case. We see more diabetics that never need us than diabetics that do. Okay, so the insulin dependent, though, they're the ones that are more prone to medical emergency. The non-insulin dependent diabetics, these are typically what we call type 2 diabetics, and they're managed more so with oral medication. Metformin probably being the most common. It used to be type 1 diabetics were juvenile onset, so they became diabetics when they were kids, and then they have it for the rest of their life. Type 2, adult onset diabetes, was more genetics, not the best diets, heavy sugar intake that they turn into type 2 diabetics. Today, that's different. We are seeing insulin-dependent diabetes in adults, in older age. So it's not really important for us to identify if they came on when they were a kid or an adult. It's more important, do you take insulin or don't you take insulin? Both are prone to high blood sugar or low blood sugar problems, but the insulin dependent are more concerning. So you'll see, how should I say, a lot of people in hospitals, at least my experience, is they might tell you they're a diabetic or they're pre-diabetic, which technically we're all pre-diabetic. We have the potential to become diabetics. But they might go in for a checkup and a doc says, you're bordering diabetes, so you better start making some diet changes, or here's some medicine to take. And people just hear that and, well, I'm a diabetic. So diabetes is very common when we're doing a medical history, so we're doing that sample, that P, past medical history, and we'll say diabetic. And then you take insulin. Right? Either way, we'll check a blood sugar on them at some point. But, so, two major problems happen. Blood sugars can get really, really low, which means all the sugar is leaving your blood going into your cells. Obviously, for that to happen, you have an excess of insulin. So too much insulin in your body is taking all the sugar out of your blood, putting it in your cells. Okay. So for blood sugars to get low, they're typically insulin-dependent diabetics that are taking insulin and something happened. They either didn't eat or physical activity changed, their body's metabolic needs changed. There's a lot of different things. Alcohol consumption can burn through sugar. So like diabetes, insulin-dependent diabetics are told you shouldn't drink. Do they always listen? Absolutely not. So you take an insulin-dependent diabetic, it's a wedding, and they decide, well, I'll just have a couple drinks tonight. More often than not, because that alcohol is gonna make them start using sugar a lot faster, their blood sugar is gonna rapidly decline. So when people's blood sugar gets low, this is usually what I would call acute to sudden onset of symptoms. This happens very, very quickly. If anyone knows a diabetic, especially an insulin-dependent diabetic, they can typically sense when I need sugar. And you may see them come up to you and go, I need something to eat, I need something to eat right now. They know if we wait 10 minutes, they could go unconscious. So that diabetic that's saying, I need something to eat, get them something to eat. Get a can of soda, some type of sugar. You know, we eventually want to get them some more, you know, carbohydrates and some better stuff to eat, but a candy bar, something
Does
to
it have
put.
to be real sugar?
No, can you choose?
No, but like, what if it's like, you know, sucralose or like a Diet Coke? I just think about I'm thinking about what we have at Windman, and I'm like, what would I hand
It
somebody?
still has, a Diet Coke could be better than
Okay.
nothing. But yeah, candy bar, even, my grandpa was a diabetic, he'd suck on a lifesaver.
Okay.
So a lot of times, you know, but they know it's coming. So that's the patient where, that they're still awake, talking, but they're starting to act funny, or we notice, and I should even say, symptoms that will happen is they'll start to get really almost tremors, almost vision disturbances to the point where they can seize, but they'll start to get really sweaty. So we see that in diabetic, just give them sugar if they're still conscious. So I know I'm going to talk about hyperglycemia, high blood sugar in a bit, but if someone's blood sugar is high, then we give them sugar, and I'll give you an example. Normal blood sugar should be between 80 and 100. So when we check their sugar, if it says 60, that's low. If it says 150, it's higher than normal ranges. But if their blood sugar is 500, and we give someone a Snickers bar, and we recheck their blood sugar, it'll be like 580. Minor difference. But if their blood sugar is 30, you just save your life. So when in doubt, that's even in the book, when in doubt, you don't have a glucometer, if you have a diabetic with an altered mental status, and they can comfortably take something orally without choking or aspirating, give them sugar. So a tube of oral glucose here, eat this. If they're to the point of becoming altered, where we're concerned about their airway, and we talked about it on Saturday, where you could take oral glucose and rub it in their gum, you know, where they're not going to aspirate on it, but they can start to absorb some sugar. Has anyone ever heard of glucagon?
Yes.
So some diabetics carry glucagon kits. Now, glucagon, it's a shot just like we give epinephrine for anaphylaxis, but it has to be constituted, and you may have to, someone, you know, a diabetic may be so shaky that says, can you help me with this? So we've been trained how to draw out of a vial. Has everybody done that so far? So when we open up the kit, there's a syringe, and most kits, the syringe will have a milliliter of fluid in it. So we take the syringe out, then you take the vial of glucagon, which will look like a white powder. So you take the syringe, you put it in the vial, and you push the fluid in, and that's what's called constituting the mix. So you take a powder, and you mix it with the saline to turn it into a solution. It should be 1 milliliter. And then after you mix it up, you draw it back into the syringe, and then administer it, or let the patient administer it to themselves. So these are all for low blood sugars. And again, this happens very quickly. Now, for glucagon to work, how glucagon works is it basically takes stored sugar, and when sugar gets stored, it's called glycogen, and it breaks down glycogen back into sugar. So it takes a little bit of time, it's not very fast. And if they have burned up all their glycogen storage already and they take glucagon, it's not going to do anything. So, but you may see a diabetic who has that kit. It's usually looks like a little pen case, a little hard plastic that you open it up and it's got the syringe and the vial in it. That's what that is. And you may have to help them constitute it. That would be reasonable.
So if someone hasn't eaten all day? Someone hasn't eaten all day?
Yep.
There's a chance that glucagon just won't work.
Haven't eaten, but they took their insulin. So a lot of diabetics, you may hear they're on a sliding scale, which means they check their blood sugar, and what that number is, they adjust how much insulin they're gonna take. So there's a lot of different reasons, but basically the blood sugar gets low. So they get sweaty, tremors to the point they go unconscious. You may walk in, they're snoring, very sweaty, have a pulse, a blood pressure, but we just can't wake them up. So check a blood sugar, that's the number one thing we can do. And if it's less than 80, we have to get sugar into it, okay? Now, high blood sugar is the exact opposite. This is where they don't have enough insulin. All that sugar is just staying in their blood, and it's not getting in the cells. So as blood sugars continue to rise, they can go into what's called an acidotic state. Probably the most common being called diabetic ketoacidosis. And when the cells can't get sugar, it begins to break down other things in the body as an energy source. It's not as efficient, but it buys time. Okay? So when blood sugars get high, diabetics will start to lose energy. So I gotta take a nap. This is something that, again, hours to days, it gets worse and worse. This isn't something that just comes on right now. During the early stages, they'll be peeing a lot. They're peeing and then they're drinking water. They're peeing and they're drinking water. And because when all this sugar is in your blood, think of it as making it thicker, and you have sensors in your blood vessels that are sensing how thick that blood is, and your kidneys are wanting to pee that stuff out, and you're drinking water to try to dilute yourself. So where we see this is poor compliant diabetics. So diabetics that just aren't taking care of themselves anymore, or they ran out of insulin and can't afford more. So they just say, well, I'll try to limp it until next payday. Unfortunately, we run into that. You can get Narcan for free if you're an addict.
But you can't get insulin for a diabetic.
Yeah. Welcome to America. So that's usually where we see it, or some type of, maybe they became septic. Something could have changed where they start to, something happens with their insulin. The other thing we can see is someone who's maybe a diabetic that doesn't know they're a diabetic. So this would be like a pediatric patient that Billy's not, we're having a hard time getting him out of bed to go to school now because it's rather slow onset. Rarely do we get the ambulance call because someone noticed something's wrong and they've taken him to the doctor before we get there. I cannot think of one instance where we went to someone who was a diabetic that didn't know they were a diabetic. Okay, but if a friend or a family is saying, hey, little Billy, or Papa Joe they're just drinking and peeing all the time, they need to get their blood sugar and get into a doctor to get checked. Okay, those are common symptoms. But yes.
A friend in college, she kept getting yeast infections, so she went in and they tested her blood sugar, and she's like this tiny little thing. She's pre-diabetic.
Yep.
So that's, I wouldn't say it's like very common, but it's something that can happen because the yeast love the sugar amount.
And it doesn't have to be diet. So I am. In fact, you guys can check my blood sugar. I have to, like, my grandpa was a diabetic. My dad became a diabetic. It's very strong in my genetic line. So I'm what I would say high risk to become a diabetic. They were both type 2 diabetics, and my grandpa became a type 1 diabetic because the doctor told him he was a diabetic, and he said, yeah, that's your opinion, and just ignored it and didn't do anything for 15 years until I became insulin dependent diabetic. But yeah, so with high blood sugar, especially when they get to the point where they're unconscious, that when they get to that severe state, that remember their body can't use any sugar, so they're breaking down other fats and things for energy source, and they go into this what's called ketoacidosis. So they get acidic. Their pH level, their blood begins to drop. So remember when we talked about Kussmaul respirations? So this ketoacidosis, you start to produce a lot of acids, and one of the way your body works to fix that is by blowing off acids, specifically carbon dioxide. So they'll go these very deep, regular respirations. Not really hyperventilating, it's not a super excessive rate, just really deep because they're blowing off that carbon dioxide. And if you stick your nose down and smell it, it's a really sweet smell. I've only seen it a few times, but when I've seen Kussmaul respirations, they're unconscious, like we can't wake them up. So those are really, really complicated patients, and it's not as simple as just giving them some insulin quick. Because not only is they need insulin, their potassium is usually severely off, so they have to do this adjustments over a couple. They're an intensive care patient for a couple days. They go to an ICU. They're probably, in my opinion, one of the more difficult patients to manage in an ambulance. Would you agree, Steve? They got to rank up there. A ketoacidosis patient.
I mean, yeah, you're managing a lot of things. You mentioned your pH, you're managing your respiratory, you've got your diuresis going on, your sodium, your potassium, your electrolyte imbalance issues, all the diuresis you're doing. I mean, you're doing a lot of messed up labs because of DKA.
So with most glucometers, they can stop at, a lot of them have preset numbers that they don't read any higher. So let's just say, I don't know what these are, but it might be 500. So remember, normal glucose is 8,200, with the exception of newborns. So for the first 72 hours of birth, it can get as low as 40, and that's normal. But these are set, they'll read, it may say, I don't know what the bottom cutoff is, what the high one is. Every glucometer is a little bit different, but most of the glucometers I've experienced with, if it's more than 500, it'll just read high. So then we know we're dealing with a high blood sugar. We don't want to give them sugar. There's really not much beyond supportive care that we do. But low blood sugar, if we're not worried about them choking on it, give them oral glucose. And just literally pour a candy bar or a can of soda or whatever. So let's go over blood sugar quick. Now, I'll probably have everybody kind of come over here around the table. Nia, you want to check the blood sugar for me? Well, just going to kind of show everybody briefly, and then we'll let. So these are, keep a vial of test strips, and every glucometer is a little different. So to check a blood sugar, got a couple pieces of equipment here. I've got alcohol pad to clean the area first, Band-Aid because I'm going to bleed. You like these things? I don't even know what they are.
You just push it.
You push it instead of doing that.
This is what we call a lancet, something to draw the blood. It's supposed to go up capillary blood. You may see us on the ambulance, a lot of times when we start an IV, there's a little bit of blood in that IV and what we call a flash chamber. So when we get the needle into the vein, that fills up with blood to tell us we're in there. So we'll just take a sample out of that rather than poke. We try to minimize our pokes. Again, glucometers are a little different, so whichever one you may use, but they all generally have a strip that gets put into the device. So how this strip is set up, you'll see I don't know, can you guys see that little square on top? That's the sample of blood. So when I poke a finger, you're going to put that, it's going to kind of pull the blood in, and you'll see that square kind of basically turn black to tell you got blood. But when you put it in the machine just kind of automatically turns on, goes through a little booting up process. See, it's kind of flashing, telling you it's ready to take the sample. I haven't used it yet. So, Capillary works best, so usually a fingertip. Sometimes I've used an earlobe. For example, the cardiac arrest, right? So in a PMB shock state, blood flow isn't really good to the capillaries, but still pretty good centrally, so we were able to get, the earlobe. A baby, fingers are so tiny, so a lot of times on kids, I'll do what's called a heel stick. Right on the heel, we'll just tap them there, which works good, and it's not as painful there. But I like to take where I'm gonna test, and I'll put a little pressure on it to get it good and red, kind of push the blood up in there, and that's when I'll poke it. So with that, I will let Renee check my blood sugar. Is this gonna hurt?
Yeah, a little bit.
She's not very gentle when she does it.
No, the first time, that's why I don't use these anymore, like the push ones, because I pushed it to, like my friend, thank God, but I pushed it to her finger and then I pushed down and it went in a little too far. She never wanted me to.
Probably want to clean it, it's all dirty.
Yeah, that's true. Yeah, and then you have to, like, calluses and stuff, if they really callous, like, usually these fingers usually are. I go for like a ring finger, those are usually also more softer, but clean. Get everything laid out.
Kind of nauseated.
There you go.
If you take an alcohol prep, isopropyl alcohol, and you let the patient sniff it, a lot of times that can help alleviate nausea. And it is in the EMR scope.
Why is it fun?
3, 2, 1.
Okay, so I'll just show them.
It's got blood. Wipe it. Or some people say no, but it's just what I was taught, so I do it.
Well, it just takes kind of that alcohol, so you're getting a fresh sample.
So the blood filled up that little square, 96. If you want to pass it around, just don't touch his blood. Just, would you like a Band-Aid?
Yeah.
Yeah.
So I don't want to keep bleeding.
Of course.
Looks like he's gonna need stitches.
Got him good. You all right over there? Yeah. Oh, we have been a few calls where you were, no way.
Has anybody fainted because of the sign?
How about your leg? Does that hurt? No, not so much. Yeah, but it's barely hanging on. It's a tendon. 96, all right, so that's
You're good.
good, considering I ate right before class. That's, makes me feel good. That means I'm doing okay so far. But the difference is that I'm not allowed to, I get cookie crisp on my birthday.
Nice.
That's it. It's the only time.
Tell him you can have it on my birthday too.
All right, so you tell her.
So those are just one-time use, and you just,
Yep, throw the, now she's gotta go put it in a Sharps container. Yeah, that just goes in a container. That's, checking the blood sugar.
What?
Oh, does anyone, maybe during break, if we can grab some Lancet, if anyone wants to practice, I'm not gonna make you.
I'll volunteer too.
What time is it here? Otherwise, I'll finish up a few things and we'll, yeah, let me get through. Let me talk about anaphylaxis quick, so take your chairs and we'll, during break time, if anyone wants to come up and try taking a blood sugar, that would be cool. And then next week, I will, kind of warn everybody, next week we're gonna start, we're gonna do a trauma lecture. So there is gonna be, I'm gonna use PowerPoint for visual, we are gonna see injuries on the PowerPoint, which I'm sure you've seen them in your book, or some of the injuries, but we're gonna look at lacerations, avulsions, amputations, and all that fun stuff. So, if you feel queasy, if you gotta get up and step out briefly, put your head down, that's perfectly normal. All right, so, Any questions or clarification on diabetic emergencies?
At what point is it like hypercalcemia, or is it just above 100? Is it considered hypercalcemia?
Hyperglycemia, I usually, no, that's a good question. So, first off, if you got a diabetic and you check their sugar and they're talking, you can ask them, what are your sugars usually run? I would say the vast majority of diabetic patients that I've ever had to take care of, they can tell me almost exactly within 20, blood sugar is usually around 220. So where it's just where they run. So if you check it and it's 224, it's high, but that's baseline for them. So usually I start to get real red flags when you start to break that 250, 300 mark. That's, or if I do get a blood sugar, I ask them, when's the last time you ate? They say, well, I just had a peach cobbler pie 10 minutes before I had chest pain. That's probably a factor why their blood sugar's so high. In fact, if I ate a piece of cake, and then, you guys check my blood sugar in 10 minutes, it's not gonna be 96. It's gonna be much higher. So, we used to do it at the fire station. Did you guys ever do that at LifeStar? Just have a day where we are gonna eat very, very unhealthy today, and then we're gonna check who's ever got the highest blood sugar doesn't have to pay.
No, we tried as many monsters as we can to see how many PVCs you can throw. There's one guy who can really get it going, but.
We'll talk later about the Big Flats firefighter that was on wildfire wood. I'm not doing good. Just had a couple heart attacks. Just had a chest pain. I'm like, we gotta get you out. We're half a mile back. And he lit up a cigarette. Oh, I'm better now. Okay. But yeah, I would say you start to get over 300, especially in a insulin dependent diabetic. A non-insulin dependent diabetic, you can see 500, 600, and they're barely symptomatic. Case in point. So remember when I talked about drinking water, being tired, peeing all the time? It's probably 10 years ago. My mom, talking to my mom, I said, hey, haven't talked to you guys in a couple of weeks. How's Dad doing? Just checking in. She said, well, Dad, something's wrong. We're probably going to go to the clinic. He's just tired all the time, and it's like peeing all the time. So, what else? Is he drinking a lot of water? Yeah, but Aunt Connie's got him on some essential oils, and I'm like, you need to get him into the doctor. And his blood sugar was 800. And he was perfectly walked into the clinic, so, but he was able with diet and some brief little stint. He's off his meds now. But he was able to go off the diabetic meds, so something he's got to check frequently, every other month, but he was able to catch it before it progressed, if you will.
What's the highest you've seen? Is it your dad?
Oh, God, I think I've taken transfers over 1,500. Yeah.
And they're conscious?
No. No. They're intubated, we're transferring them. They're a critical patient. Yeah, those are, remember we talked about like end-tidal carbon dioxide, right? When we measure that, anyone remember the normal level?
I forgot.
35.
What is it?
35 to 40. The exhaled carbon dioxide. Cannot be, right? And it's nothing you're gonna get tested on, but that's normal, what a normal should be. You take someone in small respirations that we check their end tidal, it might be 15, which is low, but that's what's keeping them alive. So if I put a breathing tube in them and adjusted my ventilations to get it back to 35 to 45, you'd kill them. So we want to put a breathing tube in and we want to keep them at that very low, because that's what's compensating for
Until they can get to a hyperbaric, or
them.
until they can get to a hyperbaric chamber?
Not hyperbaric, they need to get their blood sugar fixed. But they, because they're peeing all the time, they're hypovolemic, so they need fluids to restore lost fluids. You need lab work because when you pee all the time, your potassium drops. So, during the early stages of acidosis, you can get hyperkalemic, high potassium, and then through diuresis get hypokalemic. So if I give insulin, that's going to drop your potassium more. So if you've got a super low potassium and I give you insulin, kill you. So these are just kind of nightmare patients. They go to the ICU.
And then there's not much you can lower them on insulin.
What's it?
I said that when you're doing the insulin, you can't lower more than 100, say 50 to 70 an hour. Unless
So
you
it's
get
kind of
fluid
a-
shift into the brain.
You adjust the sugar a little bit, then you adjust the potassium and their electrolytes, and you adjust and you adjust. So and then you're managing their carbon dioxide and their oxygen. So you've got all these different things that you don't just give an insulin shot. That would be the worst thing you can do. The fixing a low blood sugar is a sprint. Quick get them sugar, and usually they get better. Whereas high blood sugar issues, that's a marathon. We're not doing a treatment release of the high blood. They're going to the hospital. Okay. Anaphylaxis. So we had talked about, I'll do kind of anaphylaxis and then we'll take our final break. So anaphylaxis is a severe allergic reaction. And we kind of touched on this briefly that did I talk about antigens? Antigens. Did I ever use that word with you guys?
I've heard it before.
So your immune system, you develop antibodies to detect and get rid of antigens. So an antigen is a foreign substance that gets in your body through injection, ingestion. There's a lot of different things. And has anyone ever heard of like autoimmune disorders? That's where your body
Attacks itself.
attacks itself. It's a whole antibody antigen attack that's not supposed to be happening. So you can have an allergic reaction is a response to an antigen. So you're sensitive to peanut butter, or it's more common when you think about you get stung by a bee. So you get stung by a bee, it gets red, it gets swollen. That's an allergic reaction. It's a localized to the specific area where that antigen was injected. Anaphylaxis is an exaggerated body-wide allergic response. Technically, anybody could become anaphylactic at any time to an antigen. The key is you have to have been exposed to that specific antigen at some point in your life. So if you've never been stung by a yellow jacket hornet and you get stung for the first time, you won't become anaphylactic that first time. The second time, maybe. The 500th time, maybe. But not the first time. So you get that, your body senses it, you get this massive, has anyone ever heard of histamine? So histamine is a chemical mediator. It's part of your immune inflammatory response. And your body senses this, has an oversensitized reaction, and instead of just fixing it locally, it goes throughout your body. The big things that happen is, first off, your blood vessels dilate. They get big, and your capillaries become really thin, so they allow fluid to leak out much easier. So when you think of anaphylaxis, this is where you start to get these hives, blotches to really just a completely red face. They'll start to, it can affect your gut. So although I haven't seen it very much, but the few anaphylactic patients, they start to get upset stomachs, maybe feel like they're going to throw up. Stomach cramping is common. Because the blood vessels are dilating, their blood pressure is going to start to drop. So they're going to start to feel lightheaded, like they need to lay down. As you progress into anaphylaxis, like they won't be standing up because they'll feel like they have to lay down. And then you're going to get swelling, specifically of your airway structures, tongue, hypopharynx, where to the point, like ask someone, one of the first questions I'll ask, if I think Nate's had an allergic reaction or an anaphylaxis, Nate, stick out your tongue for me. So there, I can see he's able to get his whole tongue out. He doesn't have airway swelling yet. Anaphylaxis can occur very, very quickly. So someone gets exposed and within minutes begin to deteriorate. So this is like one at Windman that you could before we get there, be having to administer something. So most people who know they have severe allergic reactions carry an EpiPen with them. But I can see, especially when we get Vanessa on Winchester, I would get a kit where you would carry epinephrine there. Because even though we're here, that time delay could be detrimental. So the quicker you can get epinephrine, the better. So kind of a rapid assessment of this. I always say if someone's standing upright and like pacing and kind of, we've been called for several like anaphylactic, and Steve chime in with your experience too, but I've seen it where we get called for a bee sting, possible anaphylaxis, and we get there and the person's like pacing, kind of almost in a severe anxiety state. For me, red flags start to go down. Like, let's just calm down a second. I'm going to focus on calming them down. Because if they're upright, they're probably not going anaphylactic. Because a true anaphylaxis, their blood pressure is going to start to drop. They're going to be sitting down to needing to lay down. So if they're standing up, okay, let's just do a little bit more assessing. Check their airway. Stick your tongue out for me. Let's see your tongue. Kind of look at the exposed skin. Are we starting to see hives, urticaria? So it's kind of but that patient, maybe they are anaphylactic to some type of bee, hornet, Hymenoptera, if you will. Every Hymenoptera, or like bee, wasp, hornet, they all have a little bit different antigen. So honeybee antigen is different than yellow jacket antigens, okay? Completely different. So when that person had an anaphylactic reaction to something they got stung by before, and they, recovered from it, that was probably the scariest 10 minutes of their life. That they almost died, they got fixed, so they remember, I got stung, I almost died. They don't know what they got stung by, so it's very common that they may just get stung and hit themselves with an EpiPen. We still have to assess it, right? But, let's just start to calm them down, that maybe what they got stung by this time isn't what they're super allergic to, but they're scared, so they're patient, right? But now you match that with, you get to the patient and they're down, they're sweating, blotchy, they can't stick their tongue out. This is now anaphylaxis, and we have to get them epinephrine as fast as possible. So this is for all ages. Pediatrics, for the EMR, 2 doses. For any child, it's 0.15 milligrams. 0.15 for every one who's 12 and older is 0.3 milligrams. And you guys went through that training and looking at the TB syringe where it's 0.1, 0.2, 0.3, but you drop to that level. So halfway between 1 and 2 for a kid, up to 3 for an adult, and you just give them a shot. Get that epinephrine in quick. There's really, the only really bad things that can happen is if someone's got a really kind of a bad heart, that epinephrine can make that, it's gonna, basically it's like pushing a gas pedal on a heart. So you may work that heart hard enough that it develops an acute coronary syndrome, but we'll worry about that next. The most important thing is getting that anaphylaxis correct, okay? Yeah, I'm trying to think, what?
Can it be like a weight thing too? I know you said age 12, but there's kids can differ in size too.
I just shoot for, if it's a big kid, give them 0.3. It's not gonna, don't go down the weeds too much with it, right?
Yeah.
If it's a little toddler, 0.15. If it's a school age kid, just give them 0.3. If we're concerned about anaphylaxis. They may also have like a kit with the EpiPen. They might have some Benadryl, a Benadryl pill. Let them take that as well. But assist them or get the epinephrine into them as fast as possible.
What would you do if, say, that example you used with the honeybee and they got stung with something else and they actually aren't allergic to it and they already stuck themselves with epinephrine?
Well, they're going to be tachycardic and hypertensive for a little bit, but that epinephrine they gave themselves, it's going to last for a little bit. Epinephrine doesn't stay in the system for a long time. It's just breaking that anaphylaxis stage, so it's what we call a rescue drug. Where I've had a few anaphylactic patients that we've had to give 2 or more doses of epinephrine to bring them up. You give the epinephrine, it may take about a minute, but we should start to see them getting better and coming around. They're still gonna be very anxious and jittery, especially with epinephrine, but there's really relatively no contraindications to it if we suspect anaphylaxis. If we're doing the assessment and they're still breathing good, their airway's still good, they don't have swelling to their airway, then we want to have the epinephrine ready, because it's kind of there's not anaphylaxis, and there's anaphylaxis, and then there's the in-between of maybe anaphylaxis. So they may, in the course of a few minutes you're with them, start to all of a sudden deteriorate, where now they feel like I can't swallow, but I still ask them to stick their tongue out. So, when someone gets nervous or a panic attack, you know what other symptom is? I don't think I can swallow. So we really want to assess them. And if I notice like their tongue is starting to swell, that's kind of a trigger for epinephrine. Anything else from your experience? Otherwise,
Probably anxiety was good. Right? That's an early sign. I don't think I've seen somebody come in anxious and then go down to the lethargic. It's the meditation, I think, that really is if you're in the field, you're not going to have a blood pressure kick. You're not going to be able to see that. You're going to see angioedema, right? The airway. But then you can check their radial pulse. And I know they debunked this many years ago, but they used to say if you get a radial pulse, you have to stop overnight. So if you lose the radial pulse on somebody, you can automatically just assume that they're probably well into the throes of that histamine response, that acetylatory.
I would say shooting from the hip, if they're standing up, they probably don't need epinephrine.
Yeah.
But if they're on the ground and they're saying, I can't, I feel like I'm gonna pass out, that's where I start thinking, okay, let's start getting the epi drawn. But they could also be feeling like they're gonna pass out because they're hyperventilating and anxious. So stick your tongue out, let's kind of see where they're at, still go through your assessment, reassure them, hey, we're assessing you, everything's looking good right now, but we're ready if it gets there. So we're watching you. Once we hit that trigger point of epinephrine, I got it right here. But worst case, when in doubt, just hit them. Or not hit them, but hit them with or EpiPen, whatever you have.
Chief, can I speak to her question on the 0.15 to point? Okay, so if you're under 12, I know you're kind of worried about like that there's called a therapeutic index, kind of a range. And basically your body, if you're pediatric, will take what you need and then not use the rest, okay? So you're not gonna like kill a 3-year-old by giving them 0.15. I would even dare to say if you mess it up and you give 0.5, you're not gonna kill them either. You're just gonna, they're gonna be really anxious and you're gonna really kind of jerk their heart around. But
I don't want you guys feeling, oh, I better not, if you're leaning, I always say, especially EMR level, if you're thinking, I think I'm gonna have to give it, then just give it.
I arrived on scene and they've given pediatrics just the adult ones. Somebody just came up, I got one, and they just stamped. And kid was fine.
I've had a lot of, I shouldn't say, I've had enough calls where people have self-deployed their EpiPen when they didn't need to. $600, just like that. But I've also never been through anaphylaxis. I've seen people in it. I can only imagine, I've seen the fear in their eye. They're literally suffocating. So, yeah. Okay, well with that, we'll take our, I think it's final break. Well, Dana, grab a handful of lancets from the supplier. Okay, good. Okay. Just a few more topics that I got to cover per the curriculum with the medical emergency. So toxicology. I'll sum up toxicology is really supportive care for the most part. Big concern with toxicology that we are at the EMR level is gonna be loss of airway or loss of breathing. So, one area that has to be covered for curriculum is nerve agents. This is something that came out from the WMD. It is approved, I believe, in EMR scope to use the 2-PAM auto injectors. Nerve agents are technically a weapon of mass destruction. So, it's atropine and 2-PAM chloride, I think it is, right? 2-PAM.
I didn't hear what you said, what's that?
The
Duodos?
nerve agent auto injector, atropine, and
I don't remember what the other one is.
it's like 2 EpiPens side by
Yeah.
side. So we just have to, this was a big thing post 9/11, and then now it's kind of, it's still part of the standard curriculum. And nerve agents, they produce an acronym called SLUDGE. SLUDGE, S-L-U-D-G-E, that stands for salivation, lacrimation, urination, defecation, GI upset, and emesis. Basically, if you have an orifice in your body, fluids come out. So nerve agents stimulate essentially your parasympathetic nervous system. The risk or the likelihood of you running into that, super low. Super. And we don't even carry the auto injectors for it. It's essentially, it's like 2 EpiPens together. So you're injecting both these agents together.
What exactly does it do?
It's atropine, and I think it's 2-PAM chloride. It's if you want to get into the weeds, it's to reverse cholinergic effect. So atropine's an anticholinergic, and that's what's happening with nerve agents, is you're having a massive cholinergic response. So, continual bombardment of acetylcholine at the neurotransmitter. So, the 2 drugs are working on the muscarinic and the nicotinic receptors. But unfortunately, if it's a true nerve agent, I don't think there's enough atropine in the county to fix the patient. So standard dose, and atropine is a drug that we give somebody with slow heart rates at paramedic level, and we give up to 1 milligram. With a true cholinergic type toxicity, you need 10, 20 milligrams of atropine. We don't even carry that much. So the other big component of toxicology now is the opiate crisis, and that's administration of Narcan. So any altered mental status, we check their blood sugar, it's normal. Big indications of opiate toxicity, obviously respiratory depression. So they're either breathing really slow or not at all. Another thing you may see is pinpoint pupils. So you open up, look at their eyes, and the little black circle is super like pinpoint, tiny. Those are classic of opiate toxicity. Now, what I will tell you, unfortunately, is most of our overdoses are polypharmacy in nature. And polypharmacy means little of this, little of this, little of this. So they may take the opiate, which is suppressing the respiratory drive, but there's another drug which is actually dilating their pupils. So pupils aren't a good indicator. Basically, if someone's unresponsive, and we've ruled out a lot of other causes, we administer Narcan. And we did training on Saturday with everyone saw the intranasal Narcan, which is the most common. That's the public access Narcan that facilities are now putting with their AEDs. Law enforcement carries them. EMS, you can give Narcan in multiple different routes. We can give it intranasal, we can give it IM, we can give it IV. So Narcan can be given in multiple different ways. The thing I want to urge with caution is if we are concerned that we are going to give Narcan, we really, I'm just going to not only advocate, I'm going to tell you, before Narcan delivery, we should always have law enforcement search the victim and their immediate surroundings for any threats. Okay, and this is something I'm pretty big on, that if they're not breathing, and we're concerned that they probably need Narcan, we just bag them, ventilate them until law enforcement gets there and search them, and then once we've made sure that they don't have a weapon on or near them, then we can wake them up with Narcan. Does that make sense?
Why, like, I guess I understand, but don't, like, why is that such an important thing to do?
There is a much increased potential in an opiate overdose of violence when they wake up. So
Start swinging.
if,
It's like you ruin their high or what?
Yeah, you just ruin their high.
so if you can imagine, you just spent a lot of your money on a drug to take recreationally, and you take it, but it's toxic level. So unfortunately, when I buy a drug from Jimmy, no offense, I'm not just using a name. So if anyone knows a Jimmy, I'm not saying it, but, so let's say I wanna do meth tonight. So I go buy some methamphetamine, and I take it home, and my goal is to get a little high. But I didn't, it's not coming from a drugstore, so a lot of times that there's fentanyl and there's potential fentanyl to be in it. So I think I'm gonna do meth, and it's actually 50% fentanyl. So I shoot, snort, whatever the drug, boof it, and all I remember was going high, and then I just quit breathing. So now, I wake up, and I got a bunch of people in uniform around me, or a bunch of strangers, I potentially become violent. And the likelihood of people that do drugs aren't probably necessarily law-abiding citizen, so they may carry a weapon for their protection. So, I don't want to wake someone up quickly and abruptly and have them potentially harm me or other first responders.
Was it like Appleton or something?
Yep.
Firefighter who woke the guy up and got killed.
Yep. Yeah, that was not that long ago. Mitch Lundegaard. They Narcan the guy, didn't search him. He was still kind of coming out of it, and they're trying to talk him into going to the hospital, and he just pulled out a gun, started shooting, killed a Appleton firefighter before the law enforcement neutralized him. So, my previous department, unfortunately, we did a lot of overdose calls, and a lot of them had potential of becoming violent. So we just want to make sure that they don't have knives, they don't have guns, they don't have something that's going to hurt me. And opiate overdoses, they die because they quit breathing. So if we're ventilating them and bagging them, we have time to kind of search them. And what Narcan does is it displaces that opiate. There's a lot of different things people can overdose on, take recreationally, and you may even give Narcan to a 92-year-old female. Not because she is intentionally using recreational drugs, but she may be on pain medication and took an extra pill. Years ago, I took what was called a GEMS course, Geriatric EMS. And part of that course is they have you put on glasses and gloves that simulate, loss of vision and aging, loss of dexterity and sensation. And they had us sort Tic Tacs in a pill container. And then when you were done, take the gloves and the glasses off and look and see how compliant you are with meds. I would have overdosed by Tuesday. And that's trying to, so if you can imagine a lot of the elderly trying to sort their medications through the week, that's what we call an unintentional overdose. So, we have an elderly person, or actually anybody who's not breathing, they're probably going to get Narcan somewhere in there to rule out opiate toxicity. Otherwise, a lot of the other drugs of abuse that we run into, probably most commonly being methamphetamine, which is a stimulant. There's even a drug out there now, I think it's xylazine, that acts like an opiate, but Narcan doesn't work on it, so they quit breathing. But you can give Narcan, it doesn't reverse it. Typically, a lot of the stimulant type drugs, the big thing is they they can become violent, belligerent, and at that point, it's a scene safety issue, we just back off. Law enforcement handles it. Law enforcement, usually ALS provider, we may have to step in and chemically sedate them, so give them a shot, basically knock them out. But at the EMR level, if we're concerned about an ingested poison, so it can be ingested, inhaled, absorbed, it can be intentional, unintentional. One of the best resources we have is poison control. Of course, I don't have the number off the top of my head, I know I got it on my reference, but
I have it saved.
anytime we have a suspected overdose or ingestion, it can be kid got into something under the sink, whatever. Try to identify the substance, and we call it poison control. And even the EMR can do that, because that initiates the case. They communicate with the receiving hospital, they communicate with EMS. If you've never used poison control, it is a phenomenal resource. It's free, and when in doubt, we call them. But they're going to know what it is, how much it is, huge resource. But potential overdoses or ingestion poisons, toxicology, for us, it's supportive care. So want to check their blood sugar if the patient will allow us, and administration of Narcan, once we've secured it. And there's a big push for just give Narcan, but just my experience, I'm not a big one for anyone for like first response Narcan. I say ventilate them, wait till more help gets there. Once we've made sure it's safe, then we can wake them up. Does everyone understand that? Okay. It's just sensitive. So I'm going to skip syncope briefly and just kind of talk about GIs. The one thing in the curriculum that they want to talk about is gastrointestinal bleeds, GI bleeds that we call them. So a GI bleed is bleeding anywhere between the mouth and the rectum. So you can have upper GI bleeds and lower GI bleeds, that's what we call them, and it's kind of, what is it, pretty much the stomach is what, stomach is considered lower, stomach and lower is, so it's from your stomach on the way out, that's a lower GI bleed, your esophagus is an upper GI bleed. A lot of different causes of GI bleeding. Probably on the most severe end is what we call an esophageal varices. What's typical with esophageal varices is, I think it's probably going to be chronic alcoholism is the biggest risk factor. So you've got veins that run along your esophagus, and they dump directly into your liver. So a complication of chronic alcohol abuse is the liver is a big filter, right? And with alcoholism, that liver can get plugged up, or it's not filtered. It's like just a big plugged up filter. So that creates back pressure in these veins, and you get engorged veins in the esophagus. Very thin wall that through coughing or eating something can tear that open. And they can exsanguinate. They will be coughing up, throwing up bright red blood. Unfortunately, other than doing our best at suctioning, usually those patients we got to position forward and just let them expel the blood, but there's not much else that the EMR can do. There's actually not much the paramedic can do. We're probably going to, we got a blown varice, Steve's probably going to call a helicopter team. They got to get somewhere for a surgeon to try to fix that. They can also be passing bright red blood rectally. I've had some severe GI bleeds where it's coming out of both ends, just pouring. Not much we can do, supportive care. Some of the smaller, especially lower GI bleeds, other things that can indicate it is we'll see what's called coffee ground emesis, where if someone had thrown up, we can ask them, what did it look like? Did you see anything that looked like coffee ground? So it's just a little, like almost dried blood that's mixed in with the vomit. Super undiagnostic by visual, because you can eat stuff that can look like coffee grounds, or was there blood in it? To even on the more severe end, you may walk into a house and they got an ice cream bucket and it's full of blood, red blood. Obviously they got a GI. As far as like stool, we ask about bowel habits. It may be anywhere from passing just blood to very dark, tarry stool, where obviously the higher in the GI tract, that as that blood moves through the GI tract, it comes out more black and tarry. Now, the other thing that causes bright red blood in the stool is a hemorrhoid. We're not gonna, it's not the EMR's job to get down there and take a look. Renee can, but, if they are passing bright red blood in their stool, and, you know, all that, so like when you got up from the toilet, was it just blood in the toilet bowl, or when you wiped, there was blood on the toilet paper? You know, I mean, a bad Taco Bell night can do that, I guess. But, so it's, and again, for GI bleeds, the big concern is that they get hypotensive or hypovolemic from blood loss. So we're gonna do things to, if their blood pressure is low, we try to get them supine. But again, mostly supportive care. We're not gonna fix the GI bleed at the house. Syncope. Syncope is a word that means essentially passing out. So something caused the person to have a temporary loss of consciousness. There are a lot of things that can cause syncope. Everything from on the minor end, the psychogenic syncope. If I put a picture up of a massive trauma, body went through a wood chipper or something like that, that may cause someone to have a psychogenic syncope. That abrupt vision, the pass out, right? But otherwise, for the most part, when we get called for someone who passed out or is unconscious and we get them, they're waking up, something caused them to go unconscious. We're still gonna do our ABCs, our vital signs, check a blood sugar. But the number one thing I wanna rule out with someone who passed out is heart problems. My most concerning cause of a syncope is that their heart went on rhythm, something dropped their blood pressure temporarily. Again, not much as EMR, but we check their blood pressure, we check their vitals, and again, more supportive care, and just a lot of questions. So what were they doing? You know, tell me what you remember. So how much of it do they remember? Was it, well, I cut my hand with the saw, and then I woke up on the floor. You know, obviously that's more of a psychogenic reaction versus the, I don't know, I was going to the kitchen to get a glass of water and I woke up here on the floor with a big knot on the back of my head and bleeding. You know, they just passed out. So, again, kind of like that altered mental status, a lot of things can cause it. We're gonna do, you know, steps in the ambulance, EKG, blood sugar, vital signs, but it's pretty much mostly supportive care. And kind of the last medical emergency is environmental emergencies, and this is really heat-related illness versus cold. Cold emergencies, obviously the goal is to warm them up slowly. So if we're concerned about potential hypothermia, and again, there's mild, moderate, severe. We'll kind of start on the severe end to the point of someone who's severely hypothermic can be unconscious, can have very depressed vital signs. So if we're concerned about hypothermia, we're doing pulse checks. We're going to check pulses instead of a 10-second, maybe a 30-second pulse check. And this is 6 o'clock tomorrow morning. We get paged. I'm trying to think of an example here. Gooches. The owner showed up to work in the morning, start getting ready for the day, and there's someone unconscious out behind, been outside all night. Their core body temp might be really cold. They could be unconscious, their heart rate could be 10. When you get to that point of hypothermia, the heart is very irritable. So we really want to handle the person gently. You know, we're gonna, you know, head tilt, chin lift. You know, unless they're froze solid, you know, if we don't feel a pulse, start CPR. But when it comes time to like move the person in the ambulance, we're gonna try to do it as gently as we can. Mild hypothermia, we warm them up. Basic stuff, if they're wet, get wet clothes off. But we don't wanna start warming them if there's a chance we're going to refreeze them. So for example, we're a half mile back on let's take our New Year's Eve goal. Someone goes through the ice, right? So, get them out of the ice, we get all those wet clothes off them, and now we gotta take them by an airboat back to the ambulance. We don't wanna get the clothes off until we're at a point where we can continue the warming process. So, especially wet clothing, get wet clothing off. Basically, get them naked. If we sat them on a cot to get wet clothes off, we should sit them up, put a dry blanket down, then, because the blanket's gonna be wet. Heated blankets, passive warming with hot packs, so we're putting hot packs in kind of central areas, like in the groin, neck, and armpits, where blood flow is gonna go. We start warming those areas. That's passive warming. That's what the EMR can do. Frostbite, potential frostbite or maybe loss of sensation or whitening of the skin. Think of frostbite as a burn. And we're gonna talk about burn management next Wednesday, but dry sterile dressings. We don't try to warm it, just wrap it, dry dressings. Trying to think, other than that, you gotta just start warming. Am I forgetting anything with hypothermia? And heat-related illness, a couple different stages. There's kind of what's taught as heat illness, and that can progress to heat exhaustion, or they can go to heat stroke. Heat stroke being the most severe, and the textbook will tell you heat stroke, they may be dry and warm because they've lost the ability to sweat. But you can be transitioning from that exhaustion to heat stroke, where you still might have wet skin because you were sweating profusely. So the big thing in heat-related illness is they'll start to get altered mental status. Environment has a lot to do with it. So if someone's hot, try to get them out of that hot environment and start passive cooling. So it's the same thing as passive warming, but instead of hot packs, we're using cold packs. Firefighters are at high risk. So if you are on scene of a fire doing fire rehab, here's typical what the fireman's gonna do. They're gonna come to you, they're gonna have this hood around their neck, they'll take their bunker coat off, they'll still have their pants on, and they'll come to you and they're altered, they're really weak, they've got heat exhaustion. Number one is get that hood off their neck. And those of you know in northern Wisconsin, if you want to stay warm, what do we put? Neck gaiters, right? Seems to be so get that off their neck, get those big insulated pants off them, and passive cooling. Cold packs. We even see, wasn't that Arbor Vita, didn't they have misters there? Was anyone at that Arbor Vita fire? Really hot day.
Oh, the storage unit?
Yeah, I'm pretty sure they had like a fan, like the rehab team that missed water, so that helps with evaporation, so you get out of the sun. So if you're ever doing fire rehab and you see a bunch of people that aren't actively fighting fire sitting in the shade, you get them out of there, because we're gonna need that for rehab for the firefighters. I know that happened when we went to Arbor Vita. There was a lot of people sitting in the shade, was a precious real estate at that fire, and these kind of non-firefighters had all migrated into the shade. We had to kick them out, because that's where we rehab the firefighters. Kind of simple. If you're cold, start warming up. If you're hot, start cooling off. Heat illnesses and cold, has potential heart effect, so have an AED on standby. We're gonna do big cardiac monitoring, IV fluids, either warm or cold, depending on what they need. Otherwise, we're missing supportive care. So that's your medical emergencies in a nutshell for the EMR. And then the plan is next week we get them to trauma. So, any questions on any of the medical emergencies? And again, if you have some, bring them up next week. I'll be here unless you read my obituary.
You're so morbid.
I don't read the newspaper.
Oh, if I'm not here, that means I'm dead. Okay, other than that, that's enough.